Good morning, everyone. So we will be starting our session on perspectives in ophthalmology. I invite our chairperson, Dr. Virendra Agarwal, to kindly start the proceedings of this session.
Mic काम नहीं कर रहा. Hello. Thank you, and I again welcome you all for this session. Very early morning, first day, and this is perspective in ophthalmology. So may I invite Dr. Ruchika Agarwal? Yeah, please. Are you ready? She is going to speak on curtailing myopia progression. Are we short-sighted in our approach? As we all know, we are getting more and more myopic patients. Okay, over to you, Dr. Ruchika.
A very good morning, everyone. I think it's a privilege to start this inaugural lecture. So I'll be talking about the role of low-dose atropine in myopia. So first of all, we should understand how big is the problem. So as you can see from this graph that from past few days, the graph has shown a steep up course, and it's predicted that by 2050, the present number of 2.5 billion is going to be doubled. So what we can say that there is a tendency of myopia boom, which has been noticed in recent decades because of high incidence and young age of myopia onset. So there are various theories of, so now what we have realized is not it's related to genetic component, but doing some active intervention should be done to delay its progression. So now environmental factors, they are playing more and more role in myopia progression. So we need to act, intervene to do something, not just prescribing the glasses won't be sufficient any longer. So where are the various myopia control interventions we know? So lifestyle modification, as you can see, we need to pull the kids out of the house, and it is recommended at least 2 hours a day of outdoor activities is must. Then there is contact lenses, orthokeratology, in which we overnight use of rigid contact lenses temporarily changes the shape of the cornea. Then we have various spectacles and contact lenses, and plus we have pharmacological intervention, that is atropine, which is the most easiest to incorporate in our practices. So what does they do? They actually slow down the progression. They are not going to correct the disease, but the final refractive number where the child is going to learn is going to be altered. So previously, few other drugs like tropicamide, timolol, pyrazipine have been tried, but they have not been approved, and there is no as such proven role. Now only drug which has been approved is the atropine. What is atropine? It's a long-standing, non-selective muscarinic antagonist, and this drug has been approved. The use of 0.01 atropine is approved by CDSCO and is commercially available in India right now to use. So how does atropine work? It has a multimodality of action. It relaxes accommodation. Then it causes changes in the scleral extracellular matrix. So the scleral thinning and then choroidal thinning is inhibited. So what is the theory that is proposed is that because of the peripheral hyperopic focus on the retina, there are chemical changes going on which leads to the changes in the final axial length or final shape of the eyeball. So atropine has a role there also. So now the question is, are you using low concentration of atropine for myopia control in children, or still you are in dilemma whether to start or is it effective or not? Now if you want to use, what concentration of drops you should start, how long you have to continue for the effect to continue, or should you combine atropine with other optical methods or not? And so first of all, what is the evidence? Should we start using it, or it's like just simple refractive practice is good? So there have been few studies. One of them is ATOM, that is atropine for treatment of childhood myopia, the ATOM-1 study. It was conducted in Singapore. It had 400 children in the age of 6 to 12 years, and it compared the effect of placebo with 1% atropine eye drop at bedtime. So that was a 2 years treatment period, and 1 year was the washout period, during which we compared the 1 year was the washout period. So during the phase 1, we checked about the efficacy and clinical safety of 1% atropine versus placebo over 2 years. In the second phase, we looked for the myopic rebound after cessation of the atropine. So after, we'll be discussing the results soon. Then there was another study, ATOM2, which compared the efficacy of low dose atropine. So in the phase 1, we again compared the efficacy of 0.5, 0.10 and 0.01 atropine over 2 years, evaluation of myopic rebound in the second phase, and in the third phase, those still progressing were given 0.01 atropine over 2 years. So what was the result of these studies? It was shown that in the ATOM1 study, atropine 1% showed definite reduction in the progression of myopia, which was measured by changes the axial length and the change in the spherical equivalent of the spherical equivalent refraction. And in ATOM2, the result was that atropine 0.01% was effective and safe as well in controlling the myopia progression. So to consolidate the results from ATOM1 and ATOM2, it was like 0.01 atropine had similar efficacy at 0.1 and 0.5%. Side effects were minimal. Side effects that include photophobia, glare, and decrease near acuity. Negligible, it had negligible effect on accommodation and pupil size. The children didn't need to give, we didn't need to give extra, photochromatic glasses or near addition. During the washout, the main point was that the rebound was minimal. We can give higher concentration of atropine, but the rebound is more with the high concentration of atropine. So overall myopia progression was found to be lowest in 0.01%, lowest in the 0.01% group. Then there was another study which was conducted, that is the LAMP study, which was conducted in 2016 to 2017 in Hong Kong. So it compared the other further lower drugs like 0.05, a bit higher, 0.025% and 0.01% to assess that whether they are more effective and they can they be incorporated. So again it had various phases, the treatment phase, then the placebo crossed over with 0.05%, the washout period, and then the phase 4 to determine long-term effect of 0.05% atropine. So the results were that 0.05 atropine appears to work best over 3 years to control axial elongation. 0.025 and 0.01 were similar in first year, but they were more effective, but then they were similar in the second year. In the third year, they were all similar. So talking about the rebound effect, it was clinically insignificant in 0.05%, and 0.025 and 0.01% had no rebound effect. So to just create a clear guideline to how to go about, there was a national level expert consent statement which was released in 2021, how to treat. So what are their recommendations? So whom to treat? So the main target age group should be 6 to 12 years of age with a definite history of progression. Progression by progression we means 0.5 diopter over last 6 months and more than 1 diopter in a year. So younger age of onset, parental history of myopia, children over 12 years, if the myopia is still progressing, we can go ahead and treat the children. Very young children, which is to be noted, axial myopia is rare in children under 5 years of age. So, but if you see, then you can. For pre-myopes, there were certain recommendations like lifestyle, environmental modification. If a kid is coming to you, he's in the pre-myopic range, so you have to, especially these are the ones we need to focus about, lifestyle, environment, taking frequent breaks, giving some outdoor activity, ambient lighting while studying or near work. Now, whom not to treat because of atropinic side effect? People with Down syndrome, congenital heart conditions, cerebral palsy and asthma. So what is the best part of atropine? It is easily available, affordable, easy to administer compared to those contact lenses or your spectacles, which are not affordable by every class of patient. So how long to treat? For at least 6 months. If you see it's working, use either for 2 years or up to 15 years of age, which is longer. If a child's myopia increases when we stop atropine, we can still give it a shot for another 1 year. So what to expect? Initially first 6 months myopia might still progress, so we have to continue till 1 year. Follow up after 3 months, you have to call the patient not to see the progression or effect on, just to see if the patient is having any side effects or not. After 6 months is the earliest time to assess. So take home message is, So we start with initial treatment of 0.01% and we check after every 6 months if it's stable or it's progressing. If it's stable, we continue it till 2 years, stop treatment for 1 year. If it's stable, then it's fine. If it's progressing, then we can again restart the treatment and continue till the adolescent. If it's progressing, then we have 3 options. We can encourage more outdoor time. We can stepwise increase the concentration to 0.05%, which is nowadays considered more effective, or we can combine other intervention and we can continue till end of adolescent, and then we carefully stopping or tapering. Thank you.
Thank you, Dr. Ruchika, for giving the overall perspective how to use atropine. I myself is using, and I suppose everybody should start using now. It is side effect is almost not there. But the only thing is that the patients or parents does not do it as a compliance of 100%. So what I advise that keep an alarm of 9 p.m. and put this drop to child by the parents. Because usually we believe at 9 p.m. the parents are there and child is not gone for sleep. So that is my take-home advice. Thank you.
Right. So next we have Mastering Intraoperative Gonioscopy by Dr. Shweta Tripathi.
Pointer. It's not coming here.
Audio people, please help.
The projection is not on the screen. Yes.
Yeah.
So very good morning to all, and thank you AIOS for giving me this opportunity. So we are going to talk about the intraoperative gonioscopy. So why that is so important? Because in this emerging field of glaucoma surgeries, when we talk about MIGS, that's minimally invasive glaucoma surgery, we have to master a skill, that is intraoperative gonioscopy. So why MIGS is gaining so much of popularity? That's because of its internal approach, minimal trauma to the target tissue, modest efficacy but excellent safety, that is the key point, and rapid recovery with minimal impact on the quality of life. So if we want to choose from the different MIGS bouquet, the only requirement would be a perfect skill acquisition, that is a perfect intraoperative gonioscopy. And what do we need for that? We have to consider the points from starting from the pre-operative time to the intraoperative and the post-operative. Pre-operative, what all we can do just to finish our homework would be OPD-based gonioscopy, to master that gonioscopy in your OPDs to the larger extent. Why? Because they will help you to choose your cases accordingly, because they will help you to differentiate between a closed and an open angle. Also, it will help you to plan the surgical procedure. How? The answer comes here, that if you see an open angle, then there itself you can think in your mind that okay, for this patient you are going to plan a canal-based surgery, that's via the trabecular meshwork, or you can go for a suprachoroidal based surgery, that is via the ciliary body face. Anesthesia is mandatory for all the cases, especially when we are starting the cases in the beginning, because they will take care of the involuntary eye movements and will give you the perfect akinesia. Now this is the very important part of the presentation, the choice of the gonio lenses. Starting from the different choices, they do vary in degree of corneal contact, field of view, magnification and handle length. But ultimately it comes down to what works best in your hand. So basically the first step is to make a coordination in a hand and microscope. Here normally during surgeries we are taught hand-eye coordination, but here it would be along with that hand microscope tilting. If you see, the patient is positioned 35 to 40 degrees away from you and the microscope is tilted 35 to 40 degrees towards you. Again, going for a perfect alignment in this video, you see that the patient is shifted away from you, and since the patient is shifted away from you, the chair height is adjusted because now he has gone far beyond you. Change in the magnification is required to see the angle structures clearly. And last but not the least would be the microscope posturing towards you. So this is how, after the perfect alignment of the system next to you, with your non-dominant hand, that is your left hand or right hand, whichever, you hold the lens and you place it over the cornea after a copious amount of visco over the cornea. Now, when you talk about the corneal incision, majority of us, we are doing it through the same phaco incision from where we perform the cataract surgery. So basically, you have to put a visco-dispersive and a visco-cohesive. Placement of the gonio lens after that. And here we start with the journey. So the first case I'm going to show you is a simple releasing of the peripheral anterior synecdoche through a simple cyclodialysis spatula. As you see that this was a case of a 67-year-old gentleman who presented to us with advanced cupping. So after performing the cataract surgery and the cataract part for him, we went ahead and we placed the gonio lens over the cornea after placing the visco. This was the visualization of the angle we were getting. So initially, when, especially for the residents, if you don't get the views, don't get disheartened. You have to just align the instruments clearly. Now if you see, the view is going off. So what we do is, because of the corneal folds, you get to know that means you are putting an inadvertent pressure by that gonio lens over the cornea, and you see that some amount of heme is also obscuring your view. No problem. Take out the gonio lens, wash it off, put less pressure over the gonio lens, and now you see that there is a much better view. So this is how, with the help of a cyclodialysis spatula, you release the synecdoche. See the movements of the spatula, and gradually the angles are opening up. By I can say a dab movement and a tweak movement. Both directions you break the synecdoche. And this is how you achieve an open angle where you can even perform a further goniectomy as well. So now going to the second part, that's a bent ab interno needle, which is most commonly known as bang these days. So here you see that after placing the lens again, see a much clearer view we are obtaining here. So now if you see, here is the TM, and there you put that 24 gauge bent needle via the gonioscopic view, pinch over the TM, pick it up, and there you go ahead with a sliding movement, and you cut and excise the TM. After excising to certain clockers, you again go ahead and take out that portion of TM. Now, with that, the advent of KDB helped us a lot in this field, because when you excise with TM, there are studies which says that after some time the strictures does happen. So this introduction of KDB has really helped us. So in this case, if you see, after performing the phacoemulsification, the lens placement, a copious amount of visco is put over the cornea. The gonio lens is placed. I generally use the Swan-Jacob lens. Now see the angle structures which are clearly visible here. Now the KDB. This is the KDB which is gone inside. KDB is basically a glide blade. And with the help of the gonio lens, again you see nicely the cleft is created in this part. Again, moving into the opposite direction, you see the cleft is created here, and you move in the opposite direction as well, and you excise the TM to the extent you want to, and that is the end of the surgery. So the beginner's guide, when you're planning to start a MIGS, ask to yourself certain questions. Why offer a MIGS? For only to mild to moderate glaucomas, not ask for the advanced glaucomas. What skills do you need? Which MIGS? Again, for the beginners, the suggestion would be always go for a TM based procedure. Never offer, as a beginner, more than one MIGS procedure. And what should be done before a MIGS surgery? That's the most important part, the documentation, informed consent, and avoid MIGS if inflammation is present. So I conclude my talk with a saying by Confucius, who says, I hear and I forget, I see and I remember, I do and I understand. It does not matter how slowly you go as long as you do not stop. Thank you very much.
Thank you, madam, for giving this very informative talk on MIGS, and I think this is the time everybody should learn, because this can be done with the phaco, and at the same time there are many patients who can't afford the treatment otherwise. So how is your experience with the bang and Kahoot blade, KDB?
I'm doing a retrospective study because I've been doing this bang and KDB for the past 3 years. Bang I started 3 years back, 3 to 4 years. It was during COVID era. So results are quite comparable, but yes, bang, after 2 years, what I'm seeing in my patients, the pressures are shooting up to 1 or 2 millimeters of mercury. But KDB it's still pertaining, because as I showed in my video, KDB gives you a wider and a very clear cleft. But with bang, because it is needle which you are forming, you are making the needle like we make it for cystitome. So sometimes there are like some tissues are left. So some stricture formation occurs, some scarring happens. So the pressure starts going up to not to a larger extent, but yes, you have to be very careful with, when you do these MIGS procedures.
Good. So you feel the width of tissue you are removing is less in the bang?
It's not, yes, of course it's less in the bang, yes, very correctly said, sir. And second with that, the preciseness is less, because KDB already the blade is, I haven't shown it here, the blade is formed in such a way that it has got 2 sides of cutting. That is from the company side itself. Now in needle what you do, what I felt during my initial phase is what, since we were bending it, sometimes it's become bent, like a little bit of blunting is there on the tip. Sometimes it will not cut also. So for that, there is a 24 gauge needle which we use it. Otherwise, ideally recommended is by Arsham Shebiani is 25 gauge needle, which we don't get here, so we have to get it from outside. So this is how we started my
Okay.
journey.
What is the length you bent around?
3/4.
3/4.
Right.
Okay.
Very nice talk, ma'am.
Thanks.
So for the beginners, which lens finally to use?
So if you want to go for a pocket friendly, no financial disclosures.
Right.
So that's a Katina company which offers, they do have a right and a left hand lenses. But once you are like your institute is providing your, maybe you can opt for it. So you go for a Swan Jacob which comes via the Ocularis company. And maybe you can go for one, Vogue also, Vogue lenses, but they are little expensive. And nowadays the market is there with the hands-free lenses, because what they do is, this Glaucos company who has come up with the eye stent, they have come up with the eye prism as well. So that prism fixes on the cornea with the help of the gonio gel. So at a point your hands are also free. And besides that, there is like the biomes are there, no? In the microscope itself you can fix those lenses and your hand is free, the left hand, where you can use it for further manipulations.
Thank you so much.
Next school.
So next we have Dr. Rakesh Gupta. He's a very proficient surgeon. Dual tunnel ambidextrous phacoin cataract segment. Dr. Rakesh, please.
It's not showing.
Next is here. Is Dr. Pradeep Tewatia is here?
Yes, sir, I am here.
Okay.
Okay, thank you APU and AIOS for this opportunity. So I'll be talking about dual or double tunnel ambidextrous phacoemulsification, which I have kind of brought with my after attaining ambidexterity over last 5-6 years, and I've realized this technique is very useful in certain situations, especially when it comes to complicated cases and most importantly posterior polar cataract. So in this technique basically I make 2 tunnels, one that supranasally and other supratemporally, and it helps. Can I have a pointer please? Just yes. Yes. Yeah. So if you can see 2 tunnels, one supranasally, one supratemporally, and there are 2 side ports depending on the surgeon's choice. Ambidexterity makes it convenient because you can do it sitting at the same position, but even if you can't have ambidexterity, you can use this technique by shifting your position from temporal to nasal. So I'll be showing videos mostly. I'll try to cover up 4 videos. Like this is one video where patient had very hard cataract, grade 5 cataract and posterior polar cataract, and patient was avoiding surgery for many years. Now you can see I have made 2 tunnels, and I'm switching my phaco handpiece in between right and left hand using both tunnels. So I have not done hydrodissection, no hydrodelineation, no nuclear rotation. So after making these 4 quadrants, I'm cracking, and 4 quadrants are free, and by rock and roll method I've taken them out, and now you will see just epinucleus is left. And at the end, notice this point, there is a central thin piece, PC which is fluttering, and it is salvaged nicely because there was no hydrodelineation, no rotation, and no dissection as well. In second video, it's an interesting case where my colleague was doing this surgery. Patient had pseudoexfoliation and also phacodonesis, but during surgery, though there was after initial rotation was done, there was zonal dialysis. So my friend inserted Malugin ring. So at this stage, I took over because there was you can see there was a vitreous prolapse through zonal dialysis. So you can see now I have made a left tunnel. This was unplanned, but I made a left tunnel. So I was able to debulk the capsular bag by removing 1 quadrant from the left tunnel, and because I noticed that the zonal dialysis has increased, so I did limited vitrectomy, and then I made a Hoffman pocket to fixate a Gupta segment ring. I increased the capsulotomy size, and once Gupta segment ring was implanted, the capsule bag became very stable, and I was able to remove full cataract, and I was even lens was implanted. So this technique is very useful even during intra-op complications. Sometimes if there is a localized decimate detachment through primary tunnel, you can switch to second tunnel. If there is a iris prolapse, or for example there is premature entry, you can use second tunnel through left hand. So this is post-op 3 weeks picture of the same patient. In the third video, this is a complicated cataract with posterior synecdoche. So I plan to use a Malugin ring, but patient couldn't afford. So though I use Malugin ring even if patient can't afford, but in this I tried whether it is possible to do without ring or not. So it was a soft cataract, complicated cataract, this subcapsular cataract. So you can see in a small pupil of 3 to 4 millimeter also. And if you notice, this is a chopper which I have designed. This is available with Indo-German. This is DRG chopper shield. So this chopper has the advantage that it has a blunt tip, and it doesn't harm the posterior capsule, so it acts as a guard also. So you can see without using any iris retractor or pupil expansion ring, I have been able to remove cataract from 2 separate tunnels, and surgery could be completed. So this is another advantage. If in case you can't use a ring or retractor for any reason, so second tunnel helps. This is post-op 1-day picture. So this is another case. This is a very interesting case because this patient had a posterior polar cataract, and he has been to several surgeons. He was very desperate to get trifocal IOL, and obviously in posterior polar, bilateral posterior polar cataract, it is not advisable. So patient somehow, after learning about this dual tunnel thing, he came to me, whether I can put it or not. So I said, I'm not sure. There's no guarantee, but I'll try. And I have been successfully done, implanted trifocal lens in both the patient, both the eyes, and both eyes had PC rent. Now you can see at this point, there is a PC rent after making 4 quadrants, but because there is no dissection, delineation done, so capsule and epinucleus they are stuck to capsule. So I could remove left half of the nucleus from the right tunnel and the right half from the left tunnel. And there is a very interesting phenomena which I have noticed. If you see, the moment I press the left tunnel, the piece which was sinking came towards the phaco handpiece. So I believe this is some kind of Venturi advantage which happens by the second tunnel. So if you're trying to, if you see that any piece is sinking through the rent, you just press the second tunnel, there is a sudden reduction of pressure in the anterior chamber, and piece came to the phaco handpiece. Okay. And in this case, because femto axis is there, so which is central 5 millimeter axis, so because of femto axis, I implanted trifocal IOL and I did pupillary capture. So this is synergy IOL I am implanting, and I did pupillary capture of IOL. And this is one eye surgery. Other eye surgery also I did, and patient is 6/6 parts and N6 in both eyes, and he is happy with trifocal lens in his eyes. This is 3 weeks post-op image. You can see there is a rent visible, and lens is very well centered. I'm following up, it's almost 9 months now, there is no decentration and patient is very happy.
उसको उसके बाद वहाँ लगा देना.
So, the double tunnel at phacoemulsification has several advantages. It provides opportunity to handle nucleus and epinucleus from two different angles and position. It induces minimal stress on zonules and posterior capsule because you are not doing any nuclear rotation. It provides alternate access to cataract fragments in case of intraop complications. For example, zonal dialysis, I have shown in one case. If there is a PC rat, one of my colleagues was doing, there was a DM detachment, from the primary tunnel, so I could complete case from the second tunnel, and at the end I injected C3F gas and patient did very well. So it also keeps low pressure in the anterior chamber. So if you feel there is a nucleus or epinucleus is going back, so if you press the second tunnel and you try to use phaco handpiece, the piece may come to phaco handpiece and you can prevent nucleus drop. And it also allows maneuverability in small zones. For example, if patient has a small pupil, a small capsulotomy you have made, or sometimes there is small clear zone, for example, corneal opacity because of peripheral ulcerative keratitis. So these techniques become very useful. Indications, again, same posterior cataract, hard nucleus, especially with hard nucleus, phacodonosis when nuclear rotation is not safe or possible, small pupil, small zones. If there is extension or break in the axis, for example, sometimes there is an extension of axis opposite to the primary tunnel, you can make second tunnel, so you will be doing phacoemulsification in a safer zone. In zonal dialysis and PCNet I have shown in the video. And even in floppy iris, for example, if primary tunnel is slightly peripheral, so and if you feel there is a recurrent floppy iris, you can make second tunnel and you can which little anterior into the cornea and you can salvage the case. So this is a chopper which I have designed. It's available with the Indo-German. Thank you.
Thank you, Dr. Rakesh, for this new wonderful idea. So do you do it in all your cases, or majorly which cases do you do this technique?
No, sir, not all the cases, but yeah, in all posterior polar cataract, I have made it a routine because hydrodissection, delineation and nuclear rotation is avoided. In certain cases, for example, small pupil, if it is required, so second tunnel becomes an option. In piece, I've shown in some cases, it's a good, I would say, savior if there is sudden intra-op complication. Like I'm using, for example, if there is a extension of capsulotomy, peripheral extension, opposite to the primary tunnel, then I'm using it. So in posterior polar cataract, universally I'm using it now. And in fact, I'm going to publish a series which I have almost done 32 cases now. I'm planning to publish that. But during surgery also, like in recent, just 4 or 5 weeks back, there was a decimate detachment from the primary tunnel, and I used second tunnel, and I could, complete the surgery. So I think there may be more challenges, which if you are in the habit of using this, it's a very good tool.
Would have a little learning curve that you use your left hand as well for the.
Yes, sir. So I started using my left hand just in 2020 before COVID. There is an interesting story also. So when I started using it, I gradually kept improving, and now I'm doing completely independent left-handed, like even capsulotomy, every step I've been able to do. In fact, I'm planning to start, there's a training course also for that, because I believe, look, people think that ambidexterity is inherent, it's innate. So if I can learn at the age of 45, started at the age of 45, so I believe it is very much possible. Yeah, there are certain tips, and you need to convince yourself that it is possible. And once you feel that it's really a good tool, I feel my cataract surgery has gone to next level now. The apprehension in any kind of challenging case has gone down. Like recently, I've started doing completely viscoless phaco up to grade 2 or grade 3 cataract. So I think when you gain confidence, obviously you start bringing more ideas and more, I would say, innovative.
Thank you. Thank you so much.
Yeah.
Thanks.
Thank you, sir.
So now I invite Dr. Pradeep Tewatia to share his views on microcrotam nuances for LASIK beginners.
According to the steep axis, you make changes in every case.
Yeah, so ambidexterity is helping me. For example, wherever is the steep axis, even supranasal in the right eye. So I am using my left hand for the supranasal in the right eye, and even left eye supranasal. So from 0 to I would say 145 degree, I've been able to make all the cases. Thank you.
Good morning, everyone. At the outset, I would like to thank the AIOS organization for giving me this opportunity. I would be speaking on microkeratome nuances for LASIK beginners, no financial disclosure to make. Jose Ignacio Barraquer was the first person who introduced manual microkeratome, and it was first used for automated lamellar keratomyolysis. And Luis Antonio Ruiz, he was the first person to introduce motorized microkeratome. So first commercially available microkeratome was automated corneal shaper. Second generation microkeratome was Draeger lamellar keratome. It was a micro precision test model. And third generation microkeratome was Hansatome, and it is commercially available from 1997. So how to choose a microkeratome? We should know the principle and working of microkeratome, know the parameters that affect the quality of the flap. Microkeratome consists of console, body, head, blade, suction ring, and foot pedal. So we can classify microkeratomes depending on non-disposable horizontal. It can be gear-driven, automated sliding, or manual. Non-disposable vertical, it can be automated or manual, or disposable, which can be cable-driven, turbine-driven, or gear-driven. Depending on movement, you can classify them into linear, such as Moria, rotatory, such as Hansatome, and pendular from Schwein. So depending on assembly, whether the assembly is pre-assembled before applying it on the eye, it is called pre-assembled or on-eye assembly. Examples are ML7 for pre-assembled, and on-eye assembly is Moria M2. It works on the principle of Randha, that is carpenter's instrument, and it is the planer which is used to fashion the wood. So during application of suction ring, we need to increase the pressure to a range of 65 mm of Hg, because we want to make the cornea flat, and this can be confirmed by the Barraquer tonometer. So in microkeratome, blade oscillates at a very high speed to and fro in a direction orthogonal to the direction of motion, and higher the oscillation speed, smoother is the cut. So these are the gear and sliding mechanisms of the microkeratome. So in Hansatome, the gear tracks of suction ring moves into the geared tracks of the head. And in Hansatome, the movement is rotatory. In Moria SBK, the motion is linear, and in this there are no gear tracks. The head slides into the tracks of the suction ring. So this is a gearless mechanism. So here the head slides into the tracks of the suction ring in a linear fashion. So this way we can create the flap. And in pendular microkeratome, there is a drop and go phenomena. The motion of the microkeratome is in a pendular fashion. The ball shape of the cutting head protects corneal center. So disposable versus non-disposable. Disposable eliminates the need for sterilization, and it requires minimal technical manipulation. Disposable instruments, they are individually packed as sterile. There is no wear and tear of head, low probability of technician or mechanical setup error, eliminates buildup of debris and potential stimulants for DLK. It's low cost, it saves time, but disadvantage is limited surgeon control over translation speed, oscillation speed, and selection of flap diameter and thickness. So the various factors which determine flap architecture, they are arcing and linear motion, quality of blades cutting edge, speed of microkeratome pass, speed of blade oscillation, and ease of pass on the cornea. So planar versus meniscus flap, SBK and newer generation microkeratome, they give us planar cut, but older generation microkeratome used to give us meniscus flap, which were thin in the center and thicker in the periphery. So this is the histological section. The lower one is the femtosecond flap, which gives us planar flap, and the upper one is from Hansatome, which gives us meniscus flap. So translation speed and oscillation speed, rate of oscillation determines the quality of flap. Higher the oscillation rate, smoother the flap. And translational speed determines the thickness of the flap. Faster the translational speed, the thinner is the flap. So depending upon translation speeds and oscillation speed, you can control the cuts per mm. And in Hansatome, there is single circular vacuum port, so risk of suction loss and pseudo suction is there. Newer generation microcuratomes such as ML7 and Moria SBK, they have four extended vacuum slits, which prevent suction loss, and there is equal distribution of suction. Most current devices cut the flap with a standard deviation of 10 to 30 micron. Sub-Bowman's keratomyces, they give us thin flaps in the range of 90 to 110 micron. These are the various available microkeratomes, in which Zyoptics give us superior hinge and Amadeus give us nasal hinge, but with other microkeratome you can choose your hinge direction. Some of the complications are buttonhole in case of steep corneas, irregular thin flap can happen, short flap can occur, free cap can occur. If the size of the free cap is adequate, then you can proceed with the surgery. If it is small, then you need to abandon it. Flap undulations can lead to macrostria because of incorrect position of flap or movement of flap after LASIK. You can manage these also. Microstria you can observe, and sometimes they resolve spontaneously. DLK, it is non-infective inflammation, and the treatment is basically topical steroids. Microbial keratitis is a dreaded complication, and it has to be managed by cornea specialist or infection specialist. Epithelial growth, if there is damage to the flap edges, you can have epithelial growth. You can treat it surgically by mechanical debridement, or you can, if the growth is peripheral, you can use anti-YAG laser in the peripheral area, so treat the peripheral post-LASIK epithelial ingrowth. So limitation of microkeratome flap, it is non-uniform in older generations, giving us meniscus flap. Newer generations, SBK, they give us planar flaps. There is thickness accuracy of 10 to 30 micron. Flap diameter cannot be controlled, difficult to perform in deep set eyes, very steep flat corneas, in corneal scars, and in cases of ocular morbidity such as filtering bleb. So an ideal microkeratome give a smooth cut. Options for creating flap with variable diameter, thickness, and location of hinge, easy to assemble. Monitoring of vacuum pressure during the procedure, easy to operate and easy to clean. Allow visualization of the cornea and durable. And it should give predictable flap thickness. So which one to choose depends upon the choice of surgeon. Discuss with experienced surgeons, rely on published data, and check the customer service in your area. Thank you.
Thank you, Dr. Thank you, Dr. Pradeep, for the nice overview of the various microkeratomes and the problems. Yes, you can choose depending on the various things, talk to the different surgeons, and thank you so much.
Thank you, sir.
So next we have no other than Dr. Virendra Agarwal, is the king of Jaipur and a wonderful surgeon and a wonderful human being as well. Keratorefractive lenticule extraction, where we stand today. Dr.
Thank
Virendra.
you, sir. Thank you for your kind words. And I take forward from the Dr. Pradeep what he said, that the LASIK keratome and LASIK was the thing when we were doing the LASIK surgery as a startup. Now the things are moving beyond the flaps. So here we are coming for the keratorefractive lenticular extraction, why we do it and where we stand. The main purpose of that, it is not that LASIK is having full of complications, but definitely there was some complications with the flap which we faced and you all must have faced. And these flap related complications are not in your hand, they are depending on the size, the place, and the patient cooperation also. So here I am going to share you my experience with the low energy lenticular extraction. I am using Zeiss Visumax. Initially I was using 500, now I am using 800, that is a Smile Pro machine. Other machines I have not used personally, but I know from the friends and other people that they are also doing good. But the basic thing is that we have shifted in the LASIK surgery from the place where we were doing something like surface or LASIK, and now the surface and LASIK means no flap is there, and because of this there are different advantages, and these advantages are not only in the cosmesis or the surgeon comfort, but these are giving a definite advantage particularly for the post-op patients. I personally had a patient with the LASIK in which he had a trauma when something was moving like this, as if someone was hitting with a stick and the flap has gone away. and there is no flap left over. And I am seeing that lucky there was no perforation in the cornea, but the flap is nowhere available, and these kind of things can happen, but these kind of things cannot happen in the smile. The similar way, we had a patient who met an accident while he was doing water sports, and he was post smile. So luckily he had a big trauma, the corneal tear was there, but everything was otherwise maintained, and we could repair the tear and maintain the good vision, because there was no flap, and the flap related complications like the wrinkles and other things and epithelial growth which can happen with the flap. So it is not the example and reason that we are doing, but we actually doing it for the reason that personally we have found that the patients are getting better vision also, because it maintains the prolate shape which is not there in the LASIK. Maybe the reasons are that we are different kind of flaps. Like you said very correctly, the meniscus flap were there initially, which was one way advantage, that the flap were thinner in the center, so you were getting more residual stroma to ablate upon. But in lenticular extraction, we are actually making a planar flaps. Now there are some machines which are not making planar flaps, they are making some different kind of flaps, but I still feel that optically, if you consider, these kind of planar flaps gives minimal aberrations, and that is the reason that I still choose and use this smile, for the reason because it is giving a lenticule which is plano on the anterior surface and having a convexity on the posterior surface, which gets submerged with the cornea because of the corneal pressures and does not induce aberrations. As well as the bigger advantage that even with a 6 mm optical zone, almost nobody is getting a glare which was there with the LASIK, because the LASIK 6 mm optical zone was not giving the exact optical zone, but it was reduced than that. And with these kind of procedures, we are getting better thing. So here I am just showing a scouting diagram. You can see that this part is basically a plano, which is remain as a cap, and this part which is grey and outlined by the red is removed from the center, and the opening can be reduced to 2 mm. There are different kind of profiles. When you say biconvex, actually you have to cut little deeper to reach into it, and when you have biconvexity, you actually weaken the stroma much more than required. Anyway, there are different kind of things and different principles, but basically the platform which are doing lenticular extraction are going to survive. There are many companies are there, so that is a big advantage. When we were alone, means one company was making and there are very few surgeons, so it was opposed by all, but now it is adopted by all, and I think future will be a flapless surgery, and it is not similar like a surface ablation. It will be a different, because surface ablation have different disadvantage based on the reason that the healing is there, and whenever there is a healing in the corneal tissue, you can't control. Some patients develop a haze which is not significant, negligible kind of haze, but there are few patients who develop haze which is significant, affecting the quality of vision and causing the regression into the number. So surface ablation is not very well controlled in your hand for the healing purpose, but when you do LASIK or you do a lenticular extraction, the healing is minimum and it is controlled, and it is almost same in all patients. Very few patients have some extra kind of healing things which can be managed simply, but in surface ablation there are some limitation. The advantage of surface ablation is that you don't require many of the equipments and the cost is not increasing except the exam laser. Here I am just going to show a complete surgery how it actually goes. एक मिनट, माउस नहीं आ रहा इस पे,
नीचे है सर, नीचे
अच्छा वहाँ दिख रहा है, अच्छा सॉरी, कंट्रोल F L, ठीक, thank you. So this is the actual real-time surgery in which we are doing, and this is 8-second laser. We are cutting the posterior surface, and now we are going to cut the anterior surface of the lenticule, and this can be removed through 2 mm. This machine, now we are having automatic shifting of the surgical part and the removal microscope, and this microscope comes on its own, and then we have to do a dissection. Dissection is really very smooth, and it is going just like a cakewalk, and you have to be very cautious that you should not have a forceful movement, otherwise you can actually do damage to the flap or cap. So this can be removed this way simply, and the biggest advantage I found that this is very smooth, and the biggest advantage, as I was showing the topography, you can see the pre-op topography and the post-op topography. So because of this kind of smoothness in the topography, the patient quality vision is very, very good. And here you can see the flap and what is the area we have done. And now we are having a machine in which it is linked with the AIOS 700 for the cyclotorsion part. And with this, the results have further increased. Though we were not thinking and having many of the patients who are having issues with the astigmatic treatment, but now we have treated up to 4.5 diopter astigmatic, and the patient's treatment is very, very good. And these are the things, how the picture comes, and then you can treat. And in this video, just to demonstrate you, you are docked, and then the machine gives you cyclotorsion part, and then the treatment can be done. And this is the way you can do. And there is a central line in which you know the visual axis, and you can actually align exactly on that. So this is giving a better quality of vision, not having a decentrations. So these are the things which are improving. I am just sharing my experience that small incision lenticular extraction is possible, and you can do just 2 mm, because there is a limitation up to 2 mm. You can't go less than 2 mm by the machine. But I think going beyond, maybe having some kind of heroic surgery, so it is better to be on safe side and use 2 mm only. It gives a very precise shaped corneal lenticule, which is not changing with the patient cooperation. There is no kind of decentration because eye is under hold when you are doing treatment. And treatment can be done almost 8 to 10 seconds as a ablation time, and myopia up to 12 diopter can be done. Hyperopia is into consideration, is done in the study, approved, but not with the commercial launch, at least in India. And custom treatments like you can do with the excimer and aberrations is not, you cannot correct. But what we have done is study, our study is showing very good results. So there is a good advantage of these kind of things, which I am not going to share. And this is the silk or J&J Elita, but what could I get the pictures from somebody, the dissection is not that smooth. The Schwinn is also come, and they are saying that we are going to treat something differently and making a shapes little better. And the similar way the Gmer is also there. So there are different machines which are there, and I feel with the time these kind of things which are going to do a lenticular extraction will survive. And it is not against LASIK or surface ablation, but with the personal experience I feel the surgeon comfort and surgeon safety is increasing with the use of femtosecond laser. It is there in other specialty also, but it comes with a big cost, which is a big challenge, that how many people can actually afford it. But if cost is not the issue, I will go for that kind of surgery, which is a lenticular extraction. Thank you for this time and opportunity. I will be happy to answer if you have any questions. Okay, tissue per diopter is almost the same, little more than new kind of laser profiles like we use MEL 90, little more than that. But if you compare the other examiners which are having little more tissue exhibition, it is almost the same.
So for low myopia, it will take more tissue because there is a refractive table, 10 to 15 micron. So that will be additional. So if you are ablating 1 diopter, correcting 1 to 2 diopter, it will be ablating 10 to 15 micron more than compared to the excimer. But in cases of high myopia, it will be the same what sir is saying.
So for 1 or 2 diopters, I feel usually we have sufficient cornea where you can spare 10 to 15 micron extra. Yes. So and that is just for the surgical safety. When you add on the 10 micron over that, the lenticule become to handle. When you want to dissect 2 layers separately, you want to have sufficient kind of thickness into the lenticule, like means minimum 30 micron should be there in the lenticule to remove that lenticule as a separate layer for the anterior surface and the posterior surface. Otherwise, it may actually puncture or you can tear the thing. So that is it. No, we usually use 6. 6.5 is actually not required with the lenticular extraction, which was there with the LASIK removal, because the effective optical zone in LASIK is reduced than what you feed in computer, and in here it is actual. It is actual. So that is the advantage. Yeah.
So sir, have you stopped doing surface ablation or you still
No, I have not stopped because there are many patients who go in military from Rajasthan.
Yes, yes.
So the surface ablation is the thing.
And in borderline corneas where there is suspicious topography, you should always do surface ablation.
I have my own reservation that whenever you are in doubt, don't treat.
Surface ablation is much safer in case the patient has job aspiration and he
No,
is
job aspiration is a big reason, and
So
I
in
agree
those
with you when there are
cases-
some thin corneas you can
Yes,
do.
you can do
But
surface
if
ablation.
don't do LASIK or any refractive surgery
Yes.
when you feel the cornea is in doubt.
Yes, yes.
Thickness is
So
not in doubt.
creating a flap will weaken the cornea more than doing surface ablation.
Yeah. For this, I will add on just that LASIK, you create a full flap, means almost out of 360 degrees, 320 or 330 degrees cut. So all the surfaces are cut. In SMILE with the reverse, you just cut it.
So, but again, the cap doesn't give support
I understand
to
that
the
still
residual
studies are
stromal,
there.
right? It is the
Already cleared off that the ectasia rate, whether we cut the cap or we dissect the lenticule is virtually
it's the same. It's only the surface ablation which leaves you compact cornea.
So-
It's much safer to prevent post LASIK
So
ectasia.
for that, what I say, the people who believe that with the SMILE you can reduce the RST, you can't. The maintain the RST same like LASIK, then
Yes.
ectasia will not be there. Almost I am doing for 13 years, no ectasia. So I am happy to
But
convert
ectasia
into
has been
RST.
reported in lenticle based surgery.
No,
So
it is reported.
Yes, yes,
I'm
sir.
not saying. But reporting means there are formoplasty cases and you do the LASIK, then you will have a problem. You do SMILE or LASIK, whatever you do, then you will have a problem.
Thank
So
you,
that is the
sir.
issue. Thank you.
Now, can we have our next speaker, Dr. Mohit Khatri? He would be presenting on cataract surgery in diabetics, key perspectives.
Good morning, everyone, and I'm very much thankful to AIOS for giving me this opportunity to share my few cents on a very basic topic. What exactly I want to emphasize here that today cataract surgery and diabetic retinopathy, they have a very complex interplay between each other, and it's not a solitary act which one has to perform. It's an interplay between two surgeons. It's a complex mechanism, and we should respect the phenomenon of diabetic retinopathy going along with cataract surgery. Doing cataract surgery is not just one job being done. You need to give space to the other surgeon, and medical legally it is going to be very important. We have to document and we have to manage diabetic retinopathy along with cataract surgery. So when you see the patient in your OPD, just don't look at the blood sugar levels. One important thing is see if the vision has dropped suddenly or it has been a slow process. If it is a rapid onset or a sudden phenomenon of drop of vision, have a red flag sign. And if everything looks normal also, take the history of anti-VEGFs, lasers or any retinal surgery being done in the patient. Or if the patient has been using some anti-glaucoma drops. If there are comorbidities, again, you have to be very much alert. When you examine your patient, don't just see diabetic retinopathy and cataract, see the ocular alignment of the patient also, and be very careful at the lid margin. These are the areas where the problem arises. One has to be very, very cautious about the pupillary dilatation and see the patient undilated also for any subtle signs of NVI. Don't have to ignore them, and don't just see the macula and the cataract, have a very critical look at the disc also. Sometimes optic neuropathies keep hiding and then you have a suboptimal outcome of the cataract surgery. When you investigate, just don't see blood sugar, fasting PP, have your HbA1c done, and AIOS task force says that fasting blood sugar less than 140 and RBS or PP less than 200 will suffice, but have your own protocols. Do an FFA if the best corrected visual acuity is not corresponding with the cataract. OCT is must, but FFA has to be decided. If needed, go for it. B-scan, specular, all that is optional. Be very careful with biometry if the patient is having vitreous hemorrhage or an oil in situ. And if a single eyed patient is there, then only go for a conjunctival smear. Don't consider any fancy ringed IOL in such patients. Always prefer a single piece acrylic hydrophobic IOL. EDOFs are okay. Toricity needs to be respected. When you are operating, it's very important that you should be well versed to deal with a small pupil. You need to have your pupil expanding devices at the backup, or you need to be well versed in managing through small pupil. Don't make a small capsular excess. You need to have space for the other surgeon also to look into the pupil. Thereafter, maybe lasers are needed, surgery is needed, so there is no space for capsular phimosis. Don't have residual cortex. try to have all the maneuvers done in the bag, and so that you don't need to have to give to oral steroids and all other things, and don't decompensate your cornea thereafter. Always give intracameral antibiotics and ensure a watertight closure. Post-operatively, if you go by science and the published data, many of these patients have a subclinical CME developed. We don't go for an FFA out there after cataract surgery. If all is going on well, who investigates? And yes, it's rightly done. But these patients need a longer follow-up. I prefer to give them a long-term NSAID drops to prevent all these things. And then if anybody comes up with a suboptimal vision after cataract surgery, don't just ignore, go for a follow-up OCT and see what's happening. Important case scenario is if you have a cataract patient with NPDR with no involvement of macula. This is going to be a routine case, go and operate, just have a longer follow-up, optional to see a follow-up OCT after 6 weeks of cataract surgery and give a long-term NSAID drop. Now, if you have a patient with cataract with NPDR and a CSME, I prefer to dry up the macula first. If the media is clear, try to dry it up, give anti-VEGFs, maybe a focal laser, and then do cataract surgery. Don't be in a hurry to jump for cataract surgery, it will worsen it. And if the media is very bad, you are not able to see the macula and all, then do a cataract surgery combined with an Ozurdex, and then analyze the situation thereafter and take a call. If you have a PDR with cataract, this is important. So look at the macula, do an OCT. If there is a traction involving macula, then it is going to be a phaco with PPV with laser. But then if traction is not there, then you can go with phaco with anti-VEGF and quickly do a PRP as the media permits. So what not to be done is just doing cataract, having a good post-op follow-up for a month and referring to a VR surgeon. That is going to be digging a grave for the patient. So what not to be done is more important. We don't have to do cataract surgery plain for a PDR patient. If you have a PDR with cataract, manage PDR along or before jumping into cataract surgery. Now a patient comes with a mature cataract and a vitreous hemorrhage. Never miss an NVI. If you're sure that there is no NVI, what my preference is a combined surgery or cataract with an early vitrectomy. We don't have to again wait for a month and then refer for a vitreous hemorrhage treatment. If you are planning a combined surgery or if you are well versed to do the same together, it's best. If not, then suture the wound and within 5 to 7 days go for a vitrectomy. So if there's no traction, I'll give an anti-VEGF with phaco, and third day or within the 5th day a vitrectomy is going to be done. If not, then together. So the most difficult part, if there is cataract with NVI, first of all document, image, show it to the patient that this is not going to be simple. If media is good, do laser, laser and laser. As far as possible, try to laser, indent, do an LIO and then give an anti-VEGF and then do cataract surgery. If media is bad, this is the worst case scenario. Give anti-VEGF and plan phaco plus minus TRAB or AGV, whatever you can do if pressures are out of control, and then jump in for a PRP or PPV. If media is bad, then vitrectomy. If media is good, then laser. So my conclusion is that in these patients you need to walk an extra mile, document it well to safeguard you and your patient, give some extra chair time to the patient and be prepared for surprises. Thank you.
Thank you, Dr. Mohit, for giving a very wide overview and giving the warning signs what to do, what not to do in diabetic. And these are the patients which make the almost 10 to 20% of our practice into today's era that diabetics is common in cataract patients. Now we are going to ask Dr. Ashwini Kalia to present hard cataract phaco, new energy saving times.
But we often encounter black and brown cataracts in our daily practice. Most of the eye surgeons like vertical chop and do not prefer horizontal chopping because a lot of force is required to break the hard nucleus between chopper and phaco tip, which can cause nucleus torque, dangling and other complications. To overcome these difficulties, I devised a new chopper for horizontal chopping, which has unique multiple sawtooths, which provide contact at multiple points and chop hard nucleus in a very controlled manner. This 2 millimeter vertical limb and terminal is blunt. First place the chopper in the left side pointing, then supinate the hand. I am not using any phaco energy or for holding or for any vacuum, just only irrigation. You can see the whitening of the lens fibers because compression forces are applied between the chopper and this phaco probe acts like a shovel. A lot of energy is saved because no trenching and nothing. Even in subsequent chopping also, just I crush the nucleus pieces between the chopper and the phaco tip. No vacuum or ultrasound energy is required. Ultrasound is required only for final emulsification of the fragments. Because the chopper does the job of holding the nucleus pieces because of this 2 millimeter just placing the probe and then crushing into the Another advantage of chopper is that it also acts like a scaffold for the last pieces. It helps in stuffing also, and as well as protecting from fragment from the chattering and causing sometimes injury in during the last pieces. It keeps some control over that also. Very less energy is required for phacoemulsification of these fragments. I am comparing the vertical and horizontal phaco. On the left side it looks like a mature cataract, but actually it is a hard cataract. In vertical chopping, the nucleus pieces are like broken pieces of glass. The hardness of pi of nucleus is same as the original nucleus. Moreover, you can see there is a rotation of the nucleus during this, in this case, vertical chopping. That can cause stress on the posterior capsule as well as zonules. And there is whitening of the lens fibers in the horizontal chopping, which causes softening of the nucleus. You can compare the pieces of nucleus after horizontal chopping as well as vertical chopping. The margins are sharp and the strength is, hardness is same, but here the hardness is decreased, so there is less energy, especially with many eye surgeons have lower end phaco machines, and we can save the energy. If phaco handpiece or machine goes out of order and OT list is pending, or if eye surgeon doesn't have phaco machine, then attach phaco tip to IA handpiece and do bisection, quadrisection with the help of phaco tip and sawtooth chopper. Horizontal chopping through 2.2 mm incision, then remove the nuclear fragments through 4 mm limbal or scleral incision with the help of histoexpression or irrigating wire vectors or McPherson forceps. There is no requirement of vacuum or ultrasound energy for nucleofractus. So this is advantage for if anyone who wants to do SICS. This is just phaco tip attached to the IA handpiece and irrigation solution. The first step is just like phacoemulsification. Because here is there's no option of vacuum or energy for holding, and we can break the nucleus into multiple pieces just like earlier cases. I think this is a new concept. I have not heard or read about this applying phaco tip to the IA handpiece and doing cataract surgery. Chamber is well maintained, as is irrigation through the side, and then we can remove with the wire vectors through 4 mm or 4.5 mm, implant the lens. I give the name of Tejas technique to this because both are Make in India projects and both are super fast in crushing their enemy and getting the good results. I live at Firozpur, that is a 10 km from Indo-Pak border. Take home message, the myth that horizontal chopping is for soft cataracts and vertical chopping is for hard cataracts is not correct. Number 2, energy is saved in this technique which gets wasted during trenching in stop and chop. Second, 4-quadrant technique, embedding of probe into nucleus during initial vertical and routine horizontal chop and subsequent chops. Due to compression forces, there is softening of the nucleus. Here both the tip as well as chopper move towards each other. So the burden on left hand decreases and hence more safe procedure. While in routine horizontal chop, phaco probe is embedded in nucleus and only left hand applies all force. High vacuum settings are also associated with increased endothelial cell loss up to some extent along with high energy. In this technique, no vacuum is required during nucleus fragmentation. Last but not the least, you get the feeling of doing phaco while doing SICS with phaco tip and my chopper. Both are phaco surgeon. Phaco means lens, as nucleus fragmentation is exactly similar in both techniques. Only difference lies in second step of emulsification or manual removal. This will help in bridging the gap between phaco surgeon and SICS surgeon. After 1 week, no one can judge whether ultrasound energy was used or not. Thanks.
Working. Hello. Thank you so much, Dr. Ashwani. Next, we have Dr. Piyush Kapoor. Sometimes things don't go the way you want. LASIK flap related complications.
Do we have Dr. Usha Johri here? Usha Johri? Next. And Dr. Renu Venugopal.
Meanwhile, he is getting ready. Renu can prepare your presentation on that side because we have to finish the session by 9:30. So may I request? AV people, please help him. पहले ये वाला तो चालू कराओ भाई.
ओके कर दीजिए सर.
इस पे आ नहीं रहा स्क्रीन पे.
एक्चुअली माउस सरक जाता है. आपको दिख रहा था, मुझे दिख नहीं रहा.
हाँ दिख रहा है सर, इस पे नहीं आ रहा.
हाँ. So meanwhile you do a setup. Can we have Dr. Renu?
Should I start, sir?
Yeah. AV people, please start the presentation for Dr. Renu. Meanwhile, they do setup for the Dr. Piyush.
Good morning, everyone. Thank you to AIOS for this opportunity. The topic of my presentation is Molecular Insights in Ocular SJS. I am a scientist at RP Center, AIMS. So, Stevens-Johnson syndrome, as we all know, is an idiosyncratic reaction of the condition of the skin and mucous membranes due to a type 4 delayed hypersensitivity reaction with respect to systemic medications or viral infections. Acute stage mortality, although is very challenging, morbidity caused during the ocular sequelae is very difficult to manage, especially in chronic sequelae stages. Ocular manifestations in these cases transfers through acute, subchronic and chronic stages. Detailed ophthalmic consultation is warranted in all stages of SDS, including the inflammatory acute stage to the cicatricial chronic SDS stage. When it comes to the causatives and molecular associations in SDS, primarily we can see genetic associations which are either HLA based or non-HLA related. HLA allele associations are primarily HLA-A 0206, HLA-B 4403, HLA-A 3301, 24.2, 0201, and all these variabilities along with the different population variations, they are all also different with respect to the causative drugs. Coming to the non-HLA genetic markers, we see quite a few interleukin polymorphism, especially in the Indian population, and IL-13, IL-4 and IL-4R receptor gene variations. Also, over the past decade, primarily research has been focused on apoptotic markers related to the acute stage in SDS, like elevated granulescence and soluble Fas ligand, Fas-L-Fas ligand pathways. Now, coming to what do we know the latest in this work is that according to a recent publication by Gibson A, single cell based RNA sequencing was done on affected SDS tissue, and it revealed T cell mediated cytotoxicity as a key indicator in SDS. What happens is that keratinocytes express markers indicating HLA1 class 1 restricted antigen representation. To have SDS, that means a person will be having a specific HLA gene risk factor as well as a specific drug neoantigen formulation. Alone, HLA allele is not enough to cause the onset of SDS as per the latest research. So a combination of two cascades a pathway leading to CD8 T cells which cause a common shared cellular responses. These CD8 T cells are present on the affected skins, and they progress the disease by sharing an apoptotic pathway throughout this, which through final stages heals and leads to activation of repair pathways like TGF-beta, JAK-STAT pathway, etc. Coming to the ocular pathogenesis of SDS, we know that it is primarily attributed to limbal stem cell deficiency, lacrimal gland obstruction, goblet cell loss on the conjunctival surface. LSCD leads to barrier function loss between conjunctiva and cornea, causing fibrovascular ingression to cover over the cornea, causing conjunctivalization and vascularization. Lacrimal duct obstruction lead to tear deficiencies, which leads to severe ocular surface dryness and squamous metaplasia. All of these contribute to the cicatricial formation of pannus in these cases. At a molecular level, I can say that the acute onset related Fas, granulescent and TNF overexpression initiates a cascade which has a systemic epidermal debridement through apoptotic ECM degradation, and also there is simultaneous limbal stem cell and tear deficiency seen. Although systemic healing occurs through tissue remodeling, what happens is that there is prolonged secretion of various interleukins and cytokines which contribute to a fibrovascular pannus. In these days, various different gene expressions are seen. Let's focus on that. A recent study has also shown from LVPI that it is primarily neutrophil and interleukin 36 alpha driven. In the acute stage, the immunopathic mechanism involves drug interaction with APCs, cytotoxic C cells and cytokine release. Concurrently, cytotoxic T cells and NK cells migrate to the skin, leading to blister development. They propose that though the target cell could be the conjunctival cells, they cause high stress related epithelial release of interleukin 8, which in a way activates neutrophils and NK cells, which leads to further ocular surface interplay. Now when we come to neutrophils, activated neutrophils are seen on a variety of diseases, but with respect to Stevens-Johnson syndrome, they are also actively involved in something called neutrophil extracellular traps. It's basically a degranulated neutrophil which upon activation releases its chromatin matter along with histone proteins, and it has been found to be a key indicator in maintaining the inflammatory surface milieu in multiple diseases. Our recent publication also, we showed for the first time that NETs are present in SDS ocular surface, and that we recommend that translational research, if focused on molecular markers, we can show the results objectively in our data. Like in our study, we have shown that we tried to give low dose heparin as a topical treatment for Stevens-Johnson syndrome eyes, and it was effective in reducing the level of NET complexes on the ocular surface, which means that heparin, which is actually a very negatively charged molecule, and it has proven capabilities of dismantling NETs. That means it lowers the effect which is caused in this syndrome on the ocular surface. So this is a representative image of the pre-treatment and post-treatment of heparin that we gave to subchronic and chronic SDS patients at RP center. And simultaneously at the molecular level, we evaluated 5 genes which are related to NET formation pathways, and we found that LDH was able to, low dose heparin was able to significantly reduce the expression of TLR9, MYD88, IL8, TNSF14 and C3A gene expression in these cases. So overall what we want to say is that even though with respect to the ocular surface, the stages of SJS also have a different gene expression pattern throughout, and a thorough study, if we are able to evaluate the difference in the genetic markers that are there, we are able to counteract them with better treatment modalities at each stage. What we need actually is now longitudinal studies which can correlate the molecular data with clinical parameters, so that we are able to analyze the data more objectively in the randomized controlled trials. We also need an efficient sampling and high throughput analysis for these cases. Thank you.
Thank you, Dr. Renu. Now I invite Dr. Piyush Kapoor to give his talk on when the things don't go the way you want, the LASIK flap related complications.
So my talk has been previously discussed by Dr. Prateek about the microkeratomes, and I would just talk about the failures which we can encounter with the microkeratomes. So in the conventional studies which showed that the failure rates with microkeratome was very low, as low as about 0.3%, but still failure is a failure, even if it is 1 out of million. So in our experience, going down straight to the issues which we encountered were epithelial defects, neovascular bleeding from the flaps, thin flaps, free cuts, incomplete flaps, tone irregular ones, decentered ones, striae, which occurred in the late post-operative course, and never ever we encountered corneal perforations, though these have been described in the literature. When we talk about free flaps, they are generally because of the malfunctioning, which may be seen in the extreme corneas, either the very flat ones or the very steep ones with the small size, the small white to white dia. And the management is never panic about it, carefully replace the flap, and always be sure that you are placing the right side at the right direction and place a BCL after drawing the flap. So this was one of the case of a very flat cornea, 18-year-old male. It had a large diameter and a flat K. We took a 0 with 8 with an SBK. And this is how the picture shows the flap came out. The flap was well placed at this edge and carefully handled. After doing the correct ablation, the flap was comfortably reposited, and it is always better to make your markings on the cornea so that ever if you encounter any such complication, you can place the flap at the right position where it has to be. So the surgery was completed successfully and the patient got a very good vision. So incomplete flaps may occur because of the patient movement or because of the microkeratome failure, which may stop before it has to be. So this is a picture you can see where the cut is even less than half of the desired one. So in these cases, this was the second case where the patient actually moved and the flap just flipped off and the lower tone edges were seen. So whenever we encounter such irregular flaps, we need to analyze that what is the zone we need to treat, whether we are getting the right correct stroma to ablate. If at all we are getting the right stroma, we can just reduce the treatment zone from say about a 6 to a 5.5, and if we are able to complete it in that zone, go ahead with the procedure and reposit the flap back. But at the same time, if you get that the flap is very small and you don't get the right edges or the right stromal bed to go ahead, it is better to reposit, abort the procedure, place a BCL, and later you can comfortably plan a surface ablation over this, or maybe take a cut deeper than the plane you have already attained. The next is, which you may encounter, a buttonhole, which generally occurs in very steep corneas when the cornea does not get properly ablated and it tends to sink down. So this is what it actually looks like. You can see the edge in the center, or you can see in these patients where you get a central island in these. So these are the cases where I would say never ever proceed with your surgery. It will always give you a very irregular ablation, and the patient will get a very unsatisfied vision. So it is better abort the procedure, again reposit the flap in a proper way, and then maybe plan a thick flap at a deeper plane, or you can go ahead with a surface ablation in these cases. Bleeding becomes a common issue when we are dealing with very small corneas and the flap goes almost to the edge of the limbus. So these becomes very difficult to handle, and sometimes it can be so messy that you hardly get a zone which is free from the heme to actually ablate the corneas. It is better to be patient in these cases, place a sponge around the edges of the limbus, or you can take the head of the microkeratome and place it at the edge of the cornea and press it hard so that the surface gets pressed and there is no bleeding as such occurring. And at all, you can even use a phenylephrine dipped sponge to apply and just blanch the vessels around. But you need to be careful. Once I did this procedure of applying a phenylephrine sponge and the pupil just tends to dilate. If you are not very prompt and very fast in this, you can actually get a dilated pupil, which may again, just irregularize your ablation, or the pupil centration may not be possible in these cases. So your attempt has to be fast and prompt. The bleeding has to be controlled with a compression, or if you are using phenylephrine, the ablation has to be done very soon. Of course, the patients come with all sorts of, most of the patients who want LASIK have all decked up eyes, and they come with all the makeup so that they feel that the doctor sees the eyes beautifully. And this is what you can actually see, the debris in the interface. Again, these are the debris which you just need to wash out carefully, and generally instruct your assistant to better clean the eyes thoroughly before taking them up for the surgery. So best way to avoid complication is your experience. And whenever we take extreme cases, when we are using SBKs, we tend to take a stop less than what is recommended by the nomogram. Like when we are dealing with a very small cornea, instead of going in with a ring of 2, with a stop size of 7.5, I generally prefer taking it as 7. So this is your customization about your LASIK. As you customize your A constant with your IOLs, we customize our stops with the experience we gain out of our microkeratomes. But still, after doing the best of the surgery, you can of course encounter late complications. And this was one of the case who came that he said that he was having a lot of itching in the post-operative course. He rubbed his eyes so vigorously that the entire flap was lying on the conjunctiva and the stroma was absolutely exposed. So these are the cases you need to reposit the flap, but if you are doing it just blindly, you may have epithelial ingrowth coming in these cases in the post-operative times. So while repositing the flap, you need to be very careful of cleaning the stroma thoroughly, even applying a MMC over it and then repositing your flap. So you get a clean cut cornea like this. Flap striae, as has been discussed by Dr. Prateek, is another complication which we see mostly in very thin flaps or very deep ablations, like doing higher pars. So stretch the flap smooth, place it in a comfortable way, but still, all said and done, when the patient comes late and he has epithelialization along the striae, it is always better to go ahead, just remove the epithelium while removing the striae, because until you remove the epithelium, you will not be able to get a flap reposited back into its normal position and the striae may persist. So removing epithelium while cleaning the striae or removing the striae is the main key to a successful reposition. Epithelial ingrowth, again, we commonly encounter in re-ablation cases. It is easily handled by just washing the flap again or using a YAG laser. DLK, which is a sterile inflammatory condition, can of course be treated with steroids. And my tips for a successful surgery is always counsel the patient thoroughly, check your blade and machine assembly properly, take the proper size of the stop and the ring, and decide your own ablation, how you have to plan it. Thank you.
Thank you, Dr. Piyush. But because of paucity of time, we will not have discussion. May I invite Dr. Reena Sethi? And this is the last talk for this session. So
very good morning to all. Thank you so much for the opportunity. We all know that there have been a lot of advances in intraocular lenses, and that's because we are using more and more intermediate vision. So most of our activities are now the screen and a little beyond. So presbyopia correcting IOLs have changed the game of refractive cataract surgery. The treatment option has grown increasingly, and so we're going to discuss what exactly are the options. We could have a diffractive bifocal and a trifocal. It could be accommodating or pseudo-accommodating lenses, or the extended depth of focus, or the extended range of vision lenses. So these category of different lenses have different techniques that are involved in these intraocular lenses. The diffractive, bifocal and the trifocal, they aim to focus at images which are more than one focal plane, as we all know. The accommodating work on the action of the aim to changing the optical power of the eye, and the extended depth of focus, they create an elongated focus to enhance the intermediate vision. So what is going to be your approach when you have a patient of cataract? You should always remember that no one size fits all. The focal points and range differ in different technology IOL. So we must first be convinced about the technology of the intraocular lens, rather than finding it out what happens to the patient. The EDOF and the trifocal IOLs to be used in a very customized fashion. You can always have an EDOF in one and a trifocal in the other eye, but you have to customize it after weighing the pros and cons and what exactly is the expectation of the patient. And always remember that what you feel has been a 6x6 and an N6 vision is could be not very comfortable for the patient. So patient satisfaction is more important than the Snell's equity. The preoperative evaluation has been very detailed. You must understand what is the visual goal for the patient, give them enough chair time. They need spectacle independence, so understand what exactly is their day-to-day activity in which they are requiring the spectacle independence and the compromise that is acceptable to the patient, because no lens is as good as your own natural lens. So there are pros and there are cons which have to be explained to the patient, and let the patient make the choice. Patient education is very important, and staff education is also very important, because you all as a team need to make the patient understand the same requirement and the same goal. Prerequisites, these are very mandatory. You must have a good biometry. Do the biometry maybe at least 2 times or 3 times for the patient, if possible on different occasions. And management of the ocular surface disorder is very important because of the increased screen time. Most of your patients are having dry eye, so that has to be assessed. And detailed macular OCT on all patients is mandatory. Trifocals require a very healthy eye, so avoid them in patients of diabetes or where they're having uncontrolled diabetics, like already explained here. And EDOFs are more forgiving. So what is the EDOF lenses that are happening now? So there are a lot of EDOFs because these lenses are more forgiving. So they introduce the positive and the negative spherical aberrations, and these aberrations help expand the patient's overall depth of focus. So there are various types of EDOFs which are there. What is the scientific difference between all these lenses? The monofocals, if a patient requires only good distance, then monofocals cannot be beaten to it. They give you a very good distance visual acuity. But the EDOFs and the trifocals also do well and are comparable to monofocals often. The intermediate, the EDOFs and the trifocals are comparable. And when a patient is really requiring a lot of near vision like sewing, needling and all those stuff, then trifocals are a clear choice. There are different scientific differences in the halos and the glares also, because the trifocals have a design of the gaps, and these gaps cause different phase reversals, and this leads to a visual fluctuation. The EDOFs, especially the latest EDOFs, non-diffractive, don't have these gaps, so these side effects are very minimal in these patients. So which are the emerging technologies? You have the small aperture technology in the EDOFs. Now in this, what happens is there's an embedded opaque annular mask, which is a little away from the center, which blocks the unfocused paracentral rays. So allowing the central path, which is going to give you the distance vision. Then the bioanalogical analogic type of EDOFs, the refractive power is highest in the center and gradually it tapers on the periphery. The echolate design is also there, which has the incorporation of the diffractive echolate optic designs. So try and understand what exactly is there in these EDOF lenses. So what is going to be my approach? My approach is going to be that it is very important to tailor the preoperative visit to the patient's unique needs, as I discussed. Administer an in-house questionnaire to determine what exactly is the patient's need and keep it very simple. So what are the questions you have to answer? What is the patient's current refraction? What are the patient's post-operative visual goals? What can the patient afford? That is very important. The affordability is important because you need to tailor the requirements according to the affordability also. And what is going to be your recommendation? You can recommend, but let the patient decide for himself. Always remember, the myopes have always enjoyed a very good near vision. So they would be happier with a trifocal or a monovision EDOF. Listen to what they want to achieve. It's customization today. So customize the right eye, customize the left eye, and customize the need, total or overall need of the patient. And explain why a technology is or not recommended, and also financials to be discussed and addressed, because that's important. Goal is not to just help them see today, but have faith in the technology so that you can offer that it's going to last for a longer time or forever. So these are a few studies on the comparison of the EDOFs versus the trifocals, in which we've seen that the multifocals are ideal for the visual acuity at 3 points, the near, the intermediate, and the distance. But they still cannot have satisfying visual quality between the separate foci. So that's how the halos and the glares are there. And also the uncorrected distance visual acuity and the intermediate visual acuity in these lenses, there is no significant difference between the monocular group in these cases. EDOFs have always can provide better binocular uncorrected intermediate, but worse near vision. So trifocals have an edge over this in these patients. And we have to study the defocus curves for this, and we know how that the EDOF gives a better intermediate vision. So patients who are requiring more of screen time, digital screen time on their executives in offices, an EDOF is a very good option for them. Contrast sensitivity, there's not much of a difference between the EDOF and the trifocals. That's what the study says. And the quality of patient and patient satisfaction is also very much compatible, or between the patient satisfaction also very similar in these groups of patients. So what we need to also, I'll just quickly run through these slides because of the time. So this is a comparative valuation of diffractive trifocal and the newer generation, a couple of new generation EDOF lenses. And the EDOF design in the Lucidus IOL achieves a lower rate of glare and in the early period. That's what in the study was done. So we don't have many long-term studies with other different lenses. We have more on the Vivity and the Panoptics comparisons. So certain intraoperative pearls, you must have a well-certain 5.5 millimeter rexes. IOL centration is very important. When you leave the eye, just see that your Purkinje images are clear. polish the capsule. This is one step. Please take time over it, because post-op satisfaction is because if the capsule is clear, you'll have good. And manage the astigmatism. These lenses are more, unforgiving if the patient has astigmatism. So meticulous, removal of viscoelastic is important. An unhappy patient, listen to the patient, discuss and address the issue, and take care of the residual refractive error with whatever modalities you feel comfortable with. And in conclusion, it's very important to select the right patient, education of the patient, the accurate biometry, match the IOL with the patient lifestyle, and last but not the least, an excellent surgery is very important. And we are actually very much in chase of the ideal IOL it's getting heated up. I'm sure it's going to be a good maybe a newer EDOF or a newer trifocal that's going to take over, and it won't be wrong very soon that the era of under-promise and over-deliver is going to be the end of it. Thank you so much.
Thank you, Dr. Reena, for covering a very important topic. And may I invite now the chairpersons and moderators of the next session to take over the session for the next time. And meanwhile, I request a group photo of the speakers and the people on chair and monitors to come forward and have a photo.